All right, well, we are going to talk about VADs and in particular Berlin hearts because there have been a couple of them around here recently, so just to talk about their indications in pediatrics a little bit and why somebody might get one device instead of another. In adults, there are several indications for ventricular assist devices. You can get one either for a bridge to transplant, which means it's the way, the best way that people think to support you until you get a heart transplant. You can get one as a bridge to recovery, which is supporting you, until your own heart function returns, or you can get one as destination therapy, which means that you're not a transplant candidate and that you need some type of mechanical support, and this is sort of or you need some type of other support, and this is the best option for you. So those are the various reasons adults can get one. In pediatrics, the only approved indication is as a bridge to transplant. So in order for us to put a VAD into somebody, they have to be, they don't actually have to be listed for a heart transplant, but they have to be at least, we have to at least think that they're a good transplant candidate, and they have to be sort of in the evaluation process. So if somebody had like a major contraindication to getting retransplanted, then they wouldn't be a VAD candidate either. So you need to be somebody who will potentially get a transplant. You also can't be really too sick to get a transplant, or at least the outcomes of VADs, and we can talk about that in a little bit in a little while. Outcomes of VADs are a lot worse if you sort of have significant organ dysfunction going in. So there's sort of a window where you want somebody to be sick enough to where they're probably going to need a transplant, but then not so sick that they are probably too sick to do well with one. As far as the types of VADs that we do, well, so the most common type of mechanical support we do here is ECMO, and at least the VA ECMO that we generally do in this unit is it's ventricular support, and it's also sort of lung support. So it is a little bit more involved than a standard VAD, which is a ventricular assist device. ECMO is great, and there's a lot of experience in pediatrics for short-term support, ideally for somebody who's going to be sick for a couple of days and then get better. That's really what it's best for. Outcomes of ECMO for people who need longer-term support aren't very good, so it's not as good an option for somebody who you think is going to need support for a long time. Outcomes of transplanting somebody from ECMO, at least here, haven't been very good, and really around the country haven't been very good. So we have sort of a soft policy here that we won't list people for transplant from ECMO, and every once in a while we sort of break that rule, but for the most part, we prefer not to list somebody for a transplant from ECMO. So if somebody is going to need long-term mechanical support, acutely we often put them on ECMO here because that's what we're able to do the quickest, and that's what we have the most experience with, and then the goal is usually to transition them over to some other kind of long-term mechanical support. For pediatrics, the type of long-term ventricular assist device that there's the most experience with is the Berlin heart. I think in this country, at least, people have been putting them in since 2005 or 2007 is when the trial started. There have been about at least 200 put in. There's just a big paper published about the sort of experience of Berlin hearts, describing about the first 200 or so. The nice thing about Berlin hearts is that they come in a variety of sizes, from adults all the way down to small infants. And so they're the most sort of versatile device that we have in pediatrics right now. They're pneumatic pump devices, so they give pulsatile flow, which is different than some of the implantable adult devices, which give continuous flow. They're what's called paracorporeal, or they're sort of next to, they're outside of the body. The cannulas obviously go into the heart, but the pumps are outside of the body. And here, at least, we have kept patients on Berlins in the ICU. That's not true everywhere. Other institutions do send them out to the floor to a moderate care type setting. Some places even send people home with Berlins, but our practice here, we haven't done a million of them, but our practice here has been generally to keep them in the ICU. You can get a Berlin heart either for a left ventricular assist device, LVAD, or a right ventricular assist device, RVAD, or you can get a BiVAD, a biventricular assist device. We had an older patient here recently who had 2 Berlins to support both ventricles. Other than a Berlin heart, for older kids, there are actual implantable devices, where the whole device is actually implanted in the chest. And what we've done here, again, has been a HeartMate 2, which is an implantable device that's primarily used as a left ventricular assist device. And you have a little drive cable that comes out, but otherwise everything is inside the chest. And those are really designed for adults and designed as long-term support that you can leave the hospital with. So the goal for those is to get one in and then get the person recovered and then get them home. And the adult side has a very well-developed program to do that. And we had a patient here a couple months ago who was in our ICU. He was an older teenager and ended up getting a little bit worse and needing a device, and went over to the adult side and had a HeartMate 2 put in, and he actually recently got a heart transplant, so he did well.
Hey.
So that was a good result.
I didn't know that.
We right now our VAD surgeon, who's Dr. C, I think isn't sort of certified to do the HeartMate 2s, so for now the patients are going over there, but he's working with the adults to sort of get the necessary numbers and things like that to do them on his own. So our goal would be to eventually, for older kids, to do those types of devices here in the pediatric hospital. I think the minimum body surface area for one of those devices is 1.2 meters squared. Generally, it's sort of teenagers, basically teenagers, and sort of even teenagers on the bigger side who are candidates for that. And then everybody smaller, at least right now, would need a Berlin. There are several trials underway trying to come up with other options for pediatric devices and maybe other implantable devices for smaller children and things like that. We're going to be part of some of those trials, so there may be some other devices that come through here in the next couple of years, but for right now, the main option for anybody who's not like a bigger teenager is a Berlin heart. So I'll talk quickly about that, and then hopefully if people have any questions, we can talk about that. So Berlin hearts, again, are indicated for anybody who needs long-term support and primarily as a bridge to transplant. The most common use for a Berlin heart is just to support the left ventricle, and there's a lot of adult data, and there's sort of like a hot topic in adults about when somebody needs a BiVAD, or right ventricular support in addition to the LVAD. And there's not really I think there's a lot of disagreement about it still. In general, a lot of times you can have RV dysfunction that gets better when you support the left ventricle and you unload left ventricle and you lower your left ventricular end diastolic pressures, which lowers the left atrial pressures, which is going to reduce the resistance that the right ventricle is pumping against. And usually the right ventricular function improves some when you sort of unload the left ventricle like that. So often somebody, even who, if they seem to have dysfunction of both ventricles, can get better just by having a left ventricular assist device put in. There are some patients, though, whose right ventricle is so sick without really prospective recovery that they do need support of both ventricles. The recent patient that we had here had sort of end-stage transplant coronary artery disease that was affecting both ventricles, and so we were pretty confident that neither ventricle was going to get better, and that's why he ended up getting a biventricular assist device. For the most part, even with adults, BiVADs are commonly Berlins because it's a lot of stuff to put in the chest as far as trying to put two implantable devices in. There are some, you can do it, but it's less common, and more commonly even with adults who get BiVADs, they might get two Berlins just because it's hard to fit everything into the chest that they need to do.
So typically for a HeartMate, you don't do left and right typically?
Typically you don't. I think especially there's another device called a HeartWare, which I think is maybe even a little bit smaller, and I know people can do both of those in there, but usually just because you're trying to fit two things within the chest, you have to really be a big sort of person to fit two implantable devices in. So
where exactly do they implant those HeartMates?
For most of these devices, you have one cannula that's sort of, or one, an outflow going into the aorta and an inflow coming out the left ventricle or the right ventricle if it's in the pulmonary artery if it's on the right side of the heart. But that's they have different geometries, but generally you're taking blood out of the ventricle and pumping blood into the artery that ventricle is pumping to. We can talk in a minute about how devices are different in single ventricle patients, because that's obviously right now we have a single ventricle patient who's on a Berlin heart, and that's something there's a lot less experience with, and there's sort of separate issues that go along with that. But generally the idea is that you're sort of sucking blood out of the ventricle or pulling blood out of the ventricle and pumping into either the aorta or the pulmonary artery, whatever that ventricle is pumping to. So anyways, so biventricular assist devices are more rare and probably probably a lot of patients can get by just with supporting the left ventricle, and the RV function will sort of improve some. But anyways, Berlin's can function as either type of device. I just talked a little bit about this paper that was describing the first 200 or so Berlins used in this country, and they looked at outcomes and risk factors and things like that, and sort of what they found was that survival is pretty good, and that there was 75% survival to transplant with a Berlin heart, and you're taking patients who are generally pretty sick to start with, so that was actually pretty reasonable survival. The highest complication and the most common cause of death with Berlins has been strokes, and we saw that issue with the patient that we had. There's actually a 30% stroke rate in this study with Berlin, which is pretty high. Not all those strokes were major sort of debilitating things, and some of them, I think what got classified as a stroke didn't even necessarily need to have any permanent damage done, so some of them were pretty minor, but obviously, sort of as we saw, some of them can be pretty major also, and that is the major downside with Berlin's.
Was age a factor at all?
So age was one of the other main risk factors, age and size in particular. Under 5 kilos do a lot worse, and in fact, under 5 kilos with congenital heart disease, there was only one survivor in the whole series. So basically, in our view, and I think in most places' view, infants with congenital heart disease aren't candidates for Berlin heart, and so that might come up sometimes if we have like a Norwood here who is doing poorly, and then we're trying to decide, do we put them on ECMO? Usually we put them on ECMO, but when we do, they either need to get better or we'll probably have to withdraw because there's not sort of long-term support options that are good options for infants with congenital heart disease or smaller infants with congenital heart disease. Under 5 kilos with a cardiomyopathy or non-congenital heart disease still didn't do great. I think they had about 60% survival, but it was still much better than patients with congenital heart disease. So here I think we would think somebody was a candidate if they had a cardiomyopathy and they were like a 3-kilo baby. We probably would think that they were a candidate for a Berlin, or at least they might be. But somebody like a Norwood who was doing badly, or anybody with congenital heart disease would not be a candidate.
I don't know that people really realize the big difference in spectrum between the cardiomyopathy kids and the defect kids, and how much that makes a difference in their outcome. It's a big deal.
It does for sure. And even looking at heart transplant, congenital heart disease does worse, those patients overall than cardiomyopathy patients, and pretty much across the board, any type of intervention you look at, patients with congenital heart disease do worse. And now sometimes that gets a little bit confusing because a lot of the patients with congenital heart disease in these studies and in most studies are single ventricle patients, and so whether like somebody with tetralogy below who has 2 ventricles and who's repaired would do as bad, there's usually not enough numbers to sort of break that all apart. So it might just be that it's really 1 ventricle patients are bad candidates, but most of the babies under 5 kilos who would be candidates for Berlin, or who would need one, are likely to be single ventricle patients. So it's probably, I think if you have like a VSD, you're probably going to do fine with the Berlin if you have some sort of minor congenital heart disease. But in all the studies, just based on numbers, a lot of times it gets broken down into congenital versus non-congenital, and congenital heart disease patients always seem to do worse. So those were some risk factors for doing badly with the Berlin. Was small size, less than 5 kilos, congenital heart disease, and then sort of the strongest risk factors for doing poorly with the Berlin, or for not surviving, were end organ dysfunction of sort of your other organs. So renal dysfunction and liver dysfunction were the other sort of major risk factors for doing poorly. What that means probably is that, again, there's sort of a window for when the right time to put a mechanical support device in somebody is, and obviously you don't want to do it too soon because there's a 30% stroke rate, there's a lot of bad things that can happen, so you don't want to give one to somebody who doesn't need one. But also, if you wait too long and they start having other end organ effects, then you may have to some degree sort of missed the boat, and they may not do as well as they otherwise could have done. In adults, there's sort of a VAD registry called INTERMACS, and they have these different INTERMACS criteria or INTERMACS classes to sort of assess how sick you are. And INTERMACS 1 is the sort of cardiogenic shock class where you're really sort of falling apart, and those patients they've shown do poorly with devices, so there's sort of similar data with adults, that the goal is to have patients who are, you know, Intermax 3 or Intermax 2 who are sort of getting sicker but haven't yet developed sort of failure of their other organs, and I think everybody sort of agrees that once you've got to that point, it's probably too late and probably not the right thing to do. Another interesting thing in this paper was that they showed there was survival differences based on institutional volume, and that the more devices you put in any institution, sort of the better they were likely to do. And when they sort of looked at that a little bit more, their hypothesis is not necessarily that those institutions were better at taking care of the patients with the devices, but that they had learned to not put them in patients who were too sick, and that they were sort of doing a better job selecting the patients. So I think an important thing for us to remember, you know, when we're thinking about patients in the ICU who may or may not need one is, again, we need to make sure that they really need one, and that they, you know, maybe seem to be heading in the wrong direction, and that they're going to be somebody who ends up with a heart transplant probably. But we also don't want to wait too long. If we're going to do it, then the time to do it is before they start developing you know, dysfunction in their kidneys and their liver and things like that. So that is a lot of what I was going to talk about. Are there any other questions at all about devices?
So most of the questions people had asked me were about the device selection for our adult patients that we had, and also he got some IVIG and had a flash pulmonary edema episode. Just like something real general about that. I think most people, that was one of the big questions people had.
Yeah, so that is
Not necessarily Berlin heart specific, but
I think that, so his issue was that he had this sort of high left atrial pressure and this sort of ventricular dysfunction, and his left atrial pressures were high. The Berlin sort of unloads the ventricles to some extent, but he probably still had a lot of he still had some left atrial hypertension probably, and anybody like that who gets, I think he got his IVIG fairly quickly, not like, not crazy quick, but he got a fair amount of volume fairly quickly, and I think that, that just given the high pressures in the left atrium sort of backed up into the lungs and caused that sort of pulmonary edema. So that wasn't like a common, it's not like one of the classic complications of Berlin hearts or of other devices, but I think was just, a consequence of his not being able to handle the volume that he sort of got. We do IVIG a lot for a lot of the transplant patients as part of either desensitizing them or treating rejection or various uses like that, and that's not something that we see frequently. So it's not. I don't think that's I don't think people should think of IVIG as something that's really high risk for causing sort of that type of complication, and it's not a type of complication that we see, or that is one of the highly reported complications with the Berlin heart. I think it was just sort of a mix of things in his case, but I don't think that's something that will be like a recurrent thing for people with Berlin's.
Do you have any questions, Julie? You took care of him a lot.
Yeah, I think my only question is we got into the cycle